Hello and welcome to Learning Thursdays. My name is Bridget Hartman DeCenzo and I will be your host today. Learning Thursdays are offered to addiction professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. Today's presentation is Heroin and Opioid Task Force Report and Updates from New York State OASAS. Our presenters are Rob Kent, Dr. Charles Morgan, and Peggy Bonneau. If you have any questions regarding Learning Thursdays, please feel free to send us an email at learningthurs@oasas.ny.gov. And now we will begin our presentation.
Hello and welcome. This is an update from OASAS related to the governor's Heroin Opioid Task Force and the work that's been produced from that in the recent months, and just some other general updates from OASAS. And I'm Rob Kent. I'm the general counsel at OASAS, the lead for good or bad on the activities of the task force and implementing the recommendations in the legislation that was just recently passed. So very exciting time. We wanted to provide this update, but just as a quick lead-in, some statistics we wanted to put out there to just sort of level set the audience as to what goes on in our system. So according to SAMHSA, 1.3 million New Yorkers are in need of substance use disorder services, and our average daily enrollment in our OASAS programming is around 97,000 individuals. And then we have a pretty sophisticated system. We have over 1,500 treatment programs operated by 500 providers. And so with that, we're going to start to move on. To give some context, the work that we've done recently, which culminated in the legislation that the governor signed in June, was, preceded by a bunch of activity that started in real earnest in 2014. We started by creating a public awareness and education campaign, and there's multiple components to that. There's the Combat Heroin webpage. We've created short YouTube videos about how to navigate our system. We've been trying to address issues related to the synthetic drugs, and then Talk to Prevent and our kitchen table toolkits are really more in-depth materials intended to try to assist people in their communities with having the conversations about the use and misuse of drugs and alcohol. So those activities have been going on. I want to show this one video.
Team starts practice today. Coach called to see how I was doing. I blew out my knee last year, just as college football programs began calling me. I didn't realize I'd get hooked on the pain pills the doctor gave me. I never thought my life could change so fast. For now, at least, football and college are gonna have to wait. Don't let addiction sideline your dreams.
So that was one of the videos that we created approximately a year and a half ago, Peggy. The intent of it, what we've learned is a lot of individuals who've ended up becoming addicted to heroin and or opioids in particular. That one's referencing what we heard a lot. A lot of athletes end up with sports injuries, prescribed extensive doses of very addictive opioids, and end up becoming addicted. And so that was meant to illustrate one of the pathways that we found that people end up becoming addicted to heroin and opioids. And so it's just one version or one PSA out of many. There's more to come. One of the pieces of the new Heroin Opioid Task Force work is we will continue that public awareness education campaign. It's been incredibly helpful. Peggy, I think you might talk at some point today about the reach of the campaign, which has just been extraordinary. So I want to start to focus now on the other activity. So June 2016, June 22nd was, I would say, the first culmination of the work of the governor's Heroin Opioid Task Force. This is a picture of the governor, our commissioner. I was there. I was not photoshopped in the background. I was forced to be in the picture. But the governor signed 3 bills into law on June 22nd, 2016. I'm going to go into depth a little bit about some of what I think is remarkable work that comes from that. And so the 3 bills, I think, address really key issues that we heard when the task force, which traveled the state in like a 2.5-week period, what we had heard and what we had heard prior to it. And I think the legislation, to the governor's great credit, is incredibly focused on addressing the issues. So one of the issues was there were still barriers to accessing your insurance to get treatment for someone who needed addiction treatment services. So I've said it in the past that the doors to our system, to especially our bedded programs, were locked, and the insurers had the keys. And we tried to take the keys back and put the power where it needs to be, with treatment providers, with families, and with our agency to make these decisions. So what did we do? We focused, it's multi-tiered, things that we worked on, and these are my words, so I own them, but we changed the opioid madness. And you look at the slide, you can see the statistics. 2014, those are statistics from a State Department of Health opioid overdose report. 11 million opioid prescription issued in New York State in the year 2014. That's the equivalent of 55% of all New Yorkers having an opioid prescription. And then you break it down further, approximately 3.5 million New Yorkers have an opioid prescription. That's almost 1 in every 5 New Yorkers. So many of the people we found who end up on heroin started on prescription opioids. And then some don't even need to get there because they become addicted to the prescription opioids before they ever get to the point of needing heroin. And what we heard far too often and continue to hear is how prescribers really aren't educated as much as they should be about how to properly use opioids in the treatment of pain or in the treatment of injuries. And so one of the first things that is contained in the 3 bills is, as of actually today, we're taping this July 22nd, this provision of law takes effect today. Going forward after today, prescriptions for acute pain for opioids are limited to a 7-day supply, the initial prescription. And I want to be clear, it's the initial prescription and it's for acute pain. Acute pain is defined in the law, and it speaks to the prescriber making a judgment as to whether the pain is going to be protracted and long-term or if it's going to be acute and short-term. Acute short-term, 7-day supply. And excluded from the definition of acute pain is chronic care, cancer care, end-of-life care, palliative care. So I want to be really clear. Chronic pain is clearly excluded so they can still get longer-term prescriptions. Another key piece I want to mention on this provision is that if, say, you get a 7-day supply, you need the other 23 days, or you need another 30 days. We wrote language into the law that doesn't allow insurers to charge multiple copays, so you would effectively pay the equivalent, whether it's at the front end 7-day supply or split between the two, of a 30-day copay for the supply. We don't want to disadvantage financially people from accessing medications through their insurance. So that's one piece. Another piece, then this again has been spoken about and came to us loud and clear everywhere we go. Prescribers don't know enough about opioids and they're prescribing too many. So this took effect at the day the governor signed the bills. Prescribers of opioids will now, as of that date, June 22nd, every 3 years will have to take a 3-hour course addressing the issues related to prescribing opioids. And critical for us is understanding, one, how to work with people who have a history of addiction when you're treating their medical issues, especially pain issues. 2, understanding the proper use of opioids and how addictive they are and the science behind the medications and what they do and why they're so addictive. So Those are two of the key pieces. And then what we also want to talk about is how to properly treat pain. And this, again, this is educating prescribers. And when I say prescribers, I want everyone to understand I'm not talking about just physicians. It's physicians, it's nurse practitioners, and it's dentists, and it's physician's assistants. All of these individuals, if they have the authority to write controlled substance prescriptions, meaning they have a DEA registration, we want them trained and continually trained every 3 years to make sure they're current on the science and that they're doing things that address pain, but do it in a way that understands when you're using opioids, the potential problems that relate to that. One of the other elements of the bill, there's three, is now when pharmacists dispense opioid prescriptions, they're going to be handing out information that's developed by our agency, OASAS, that speaks to how to access care, how addictive the medications are, just trying to educate the world as much as we can about what they're using to address their healthcare needs. So that takes effect in October. We're already working on the materials that would be handed out so that individuals could be educated on the use of these medications. Now, with regard to treatment, this is where we made some really significant changes. They take effect January 1st, 2017. First and foremost, I want to lay out what the rule is in New York for substance use disorder treatment coverage. It's the following. You are entitled to all the care you need that is medically necessary. Remember that term, medically necessary. The way you determine medical necessity or whether it's medically necessary is through the use of some type of tool that asks questions that get you to a point where you make a decision about what the appropriate placement would be, whether they have an addiction, and then therefore where they should go to seek treatment, what level of care, inpatient, outpatient, opioid treatment, there's multiple paths. So going forward, OASAS, our commissioner, our agency, will determine the tools that are going to be used to make these decisions for substance use disorder treatment. And that's really important. We have our own tool. It's called OASAS Locator 3.0. It's already mandated for use in Medicaid managed care. We are hoping that the world will slowly but surely, well, actually not slowly, move that all insurance, private managed care, Medicaid managed care, will all be using the same tool. And I'll just speak for a minute about our tool. It's free. It takes about 6 to 8 minutes to make an assessment to determine the appropriate level of care. And it's working. As I said, it's used by mandate in Medicaid managed care. That Medicaid managed care started in New York City in October of 2015. We've have over 200,000 uses of the locator tool in New York City. It's working. The insurers tell us that, the providers tell us that, the patients tell us that, and there's about a 90% agreement. They're wasting less time on fighting about where people get care, and people are getting care. And so the tool is the most critical element, and now we will control the tool that's going to be used in New York. And then another key piece is regard to inpatient treatment. And when I say inpatient treatment, I mean detox, residential, and inpatient rehabilitation. So with regard to those services, there's no more prior authorization allowed. An individual can go to an inpatient program if, and this is the key piece, if they medically need to go to an inpatient program, the provider needs to make that assessment. And then the other key piece with regard to access to inpatient treatment is that the insurer, the managed care company, cannot come in and start to look at how long the person continues to stay at that level of care until the 15th day. So now you would have 14 days of medically necessary care in an inpatient setting, if that's what you need. And We believe that's a sufficient time for individuals to withdraw, to detox, and to reach a point where you could start to comfortably look at whether they should go to a different level of care. A lower level of care would most likely be the instance. I want to make a couple of points, though, that for clarity here. The providers are required under the law to notify the insurer within 48 hours that the person was admitted to their program, and they are also obligated in that 48-hour period to provide an initial treatment plan. So that is an obligation. We tried to balance all the interest here, but what we've done is created immediate access to that level of care if it's needed. And then we expect the providers regularly, daily, to continue to assess. That we're told that's what they do now, so this should be no difference in the way they work with patients. So there will be and should be constant review of the patient's need to be at that higher level of care. Another key element that people should understand, insurers always have the ability to go in after the care has been provided and do what's called a retrospective review or a look back to see if the care was needed. Remember, they're using our tool, so we would expect there not to be significant differences or issues. But say the provider inappropriately used our tool and the person didn't need to be in that inpatient program. What we wrote into the law was that the families, the patients, bear no responsibility for the actions of the provider. If the provider made a mistake or did something intentionally and the person shouldn't have been at that care, that's a fight between the provider and the insurance company. The family is not going to get hit with a multi-$1,000 bill at the end of a treatment episode because the provider didn't follow the rules. So that's a critical piece I wanted people to understand. Another key piece, what we've found as we've continued this, statewide review and visit. We go everywhere. We've been everywhere multiple times across the state. One of the other key things we've heard, and it was reaffirmed in the task force listening sessions, access to medications was very complicated, and I mean addiction medications. So buprenorphine, injectable naltrexone, which is also known as Vivitrol, and methadone. What we were told is that insurance companies could take 3 to 5 days to approve the use of a medication. So, and what we also know from watching it is access to medications for treating the heroin opioid epidemic are almost essential at the beginning of treatment. And so any roadblocks between a patient who needs and is willing to take the medication and them getting the medication usually means they don't get the medication and they don't take the medication. So there's two different elements to this piece. On the commercial private insurance side, there is now access to a 5-day supply of addiction medications for emergency conditions. We're working on some guidance as relates to emergency conditions, but I can tell you what we have in our, from our perspective, moving from one level of care to another level of care would be an emergency condition. You're in withdrawal, that's an easy one. Or you're at risk of entering into withdrawal. You get a 5-day supply. The 5 days should give you, your provider, and the insurance company more than sufficient time to assess the need to be continued on the medications, but you'll get them. Again, those are the rules now for the private and commercial insurance and private managed care. On Medicaid, there is no prior authorization, and this started June 22nd. So no prior authorization for buprenorphine or for injectable naltrexone. And so absolutely now, it's already in effect. You can get that if it's needed. Again, all of this is subject to the need for the medication, for the treatment. And the last key piece on insurance that I want to talk about is everybody on your policy will now be entitled to get a prescription from their physician or their healthcare provider for naloxone or Narcan, and the insurer will have to pay for that. And that seems to be a really timely addressing of an issue. You can now, because of the state's efforts, access Narcan, buy Narcan at almost every pharmacy. The issue is that the prices vary, but I've had reports to me that people are being asked to pay $150 for a Narcan kit. If you have insurance, your insurer should cover this. We all want to have these medications available so we can save our family and loved ones' lives. So now the insurers will have to pay for anybody who's on that policy to access through a pharmacy, through a prescription for Narcan. Next key piece is, and these are my words again, we give families hope. One of the key pieces, and this will take effect in September, we've created 72-hour emergency services interventions. This is the ability for a family to take a loved one to an OASAS program and to have that individual receive care when they're incapable of making a decision that they need care. So it is involuntary. We expect that it would be used in a limited way, but I want to be clear on this. It's not every place where you could go to seek this care. It's going to be facilities designated by our boss, the OASAS commissioner. The local governments can use the same facilities or designate the same facilities, but understand the threshold. There needs to be an assessment made by a physician that the person is incapacitated, therefore incapable of making rational decisions, and that they're a danger to themselves or others. And in those instances, and we hope they're few and far between, they would have the ability to have the person admitted and treated for up to 72 hours. We would hope during the 72 hours we would convince them to stay voluntarily, but we could not hold them beyond that date. And this is a really critical piece. It drew a lot of attention when the bills were being deliberated. It's one small piece. We think it's very measured. The governor talked about it being a balancing act. But for us, and the commissioners talked about this, we've traveled all over the state. We've met with families in all different circumstances, and almost all of them who've unfortunately lost loved ones to this addiction, to this epidemic. What they say is, I just wish I had the ability to do something like that when my son, daughter, niece, nephew, you fill it in, was active in their addiction and not willing to seek help on their own. Who knows what would have happened? What did happen is they continued to use, they overdosed, and they died. And we've heard that far too often. From our perspective, it's one element we think is essential as we try to take all the different attacks at this epidemic that we're dealing with. So one other element that I want to talk about to the legislation, hospitals and discharging people with addictions or at risk of addictions. This provision will take effect in December, but what we have found and what we heard, and it's been confirmed across the state, so many people with addiction issues end up in hospitals, particularly emergency departments when they're in crisis. That's where almost everybody goes when they've been reversed, by Narcan for an overdose. What isn't happening is those individuals getting any type of assistance, intervention, and linkage to addiction treatment services, or even being offered it. So, effective in December, hospitals are going to have staff trained on how to understand and recognize addictions, and then have policies and procedures in place to assist individuals with accessing treatment. And a couple of items we're working on connected to this is the concept of, especially with people who've been reversed on Narcan, introducing buprenorphine. Because I want people to understand, when you are reversed on Narcan, it saves your lives. It also puts you into immediate withdrawal from heroin or opioids. It is very uncomfortable. I don't speak from experience. I've talked to enough people. I think one of the videos in here might talk. It's an individual who we've met along the way who talks about what it felt like for her when she was withdrawing from heroin. So letting somebody leave a hospital when they've been reversed on Narcan or in active withdrawal but might be medically stable enough to let go, they're going to go back out and use. If we could introduce buprenorphine in the emergency department, maybe they don't use when they leave. And if we give them a second dose and then connect them to the hospital-based peer program that we're trying to develop, there's hope that we can get more of them into treatment. If these programs work, and we're actively talking to hospitals across the state right now to try to bring them together, we hope it makes the 72-hour hold even less of a necessary element and even more of a last resort. So one other piece now I want to talk about is, this is what we've done in the recent months. There's so much more, though, that we've been doing since 2014 with great focus. We've created 10 videos, and I call it the A to Z. It's all the way from trying to understand when your loved one might have an addiction issue, what your insurance covers, what you should expect in treatment. We created 2 to 3 minute YouTube videos. OASAS has a YouTube channel. They're all on our YouTube channel that, tries to give people really concise, hopefully clear information all the way through the process. And it's interesting. These videos, we didn't even think of developing them at the beginning. We created the Combat Heroin webpage, we created the PSAs, all kinds of posters and other materials. And there was also a work group that continues to meet that was created by the 2014 legislation. I chair that group. In the midst of one of our meetings, it was actually a medical director from an insurance company who made the comment that your websites are great, the information's concise, but what we see is a lot of families, when somebody's in the throes of addiction, don't have the wherewithal to sit in front of a computer and read a bunch of words, or even to pick up a sheet of paper and read them. Why don't we put some of that information in video form? So we've done that. We believe they've been well received. And I think at this point, Peggy, are we going to show one of the...
Yes.
So the next piece here is we're going to show one of the videos.
Addiction is a disease that doesn't just impact the individual, it impacts the family. It doesn't discriminate. But recovery, now that's real. There are various types of treatment for substance abuse. Outpatient treatment, inpatient treatment, which includes detox and rehabilitation, as well as longer-term residential treatment and community residence. There are also numerous self-help groups, such as Alcoholics Anonymous and Narcotics Anonymous, as well as Al-Anon, to provide you and your loved ones support and guidance throughout your treatment and recovery process. The first step in treatment is to complete an evaluation. This will assess your level of addiction and what would be the best treatment for you. It will include a history of your drug or alcohol use, the age when your use began, other medical issues, and emotional issues. An outpatient treatment clinic is often the best place to have an evaluation done. Throughout the various types of treatment, a patient can go from one stage to the other as they progress through their recovery. Addiction is a chronic disease which can include relapse, and thus the patient and loved ones need to stay connected for support through continued counseling and self-help. This is a continuum of care, not a one-stop to recovery, but many stops on the continuum. Remember, the person didn't become addicted in a moment. It took time, and recovery does as well. If during the process of your recovery you feel as if you or your family members' rights are not being respected appropriately, or there is an incident of a serious nature, you can reach out to the Center for Justice for Vulnerable Persons for assistance. In the last video of this series, there is a more detailed description of the Justice Center and how to access it.
Okay, so that video was of Patrice Wallace Moore, who's one of our really good treatment providers, and she gives you a run through of everything you can expect when you walk through the front door of a treatment program. We want to show you another video. Unfortunately, I wasn't the person who put this slide package together. It's a video of me talking about the law as it relates to insurance coverage and your ability to appeal when they deny access to care. So we'll play that now. My name is Rob Kent, and I'm OASAS General Counsel. We are working very hard in New York State to make sure that people can access alcohol and drug abuse treatment and that people understand the process to get coverage for these services. We will continue to work closely with insurers, providers, and consumers like you. You may have already heard about the different types of treatment available. Your insurance likely covers these services. When you are seeking services in the OASAS treatment system, there are a few important points I would like you to know. First and foremost, it is illegal for your insurance company to tell you that you must fail first at outpatient treatment before they will cover inpatient treatment. Again, this is illegal, and you should immediately file a complaint with the New York State Department of Financial Services. Whenever you are seeking treatment and the insurance company denies coverage because they believe it is not medically necessary, you should appeal that decision. There are two types of appeals, internal and external. An internal appeal is where you are asking the insurance company to re-review the decision internally. If the insurer continues to deny coverage after the internal appeal, you have the right to request an external appeal. This is where an outside entity reviews the insurer's decision to deny coverage. In addition, and importantly, if you are transferring from a detox to inpatient program or asking for additional days at inpatient treatment and your insurer denies coverage, you can appeal that decision. During that appeal, your insurance company must cover the cost of that treatment. If you disagree with the final outcome of any of your appeals, you can file a complaint with the New York State Department of Financial Services. If you have questions about a denial, contact their Consumer Assistance Bureau. Your OASAS certified provider will assist you with this process. We congratulate you on starting your journey to recovery and remind you there is help and there is hope. So first, I'll apologize for you having to watch me. I'll also probably make my wife happy that I wasn't wearing the same shirt today. So, couple other things I want to hit on, and then I'm going to turn it over to some of my colleagues here. Access Treatment webpage. We've added a page to our website. We continue to update it. All the information we've been talking about, the videos, access to the videos, access to everything we've been doing in the last number of years as it relates to addiction treatment, and in particular the heroin opioid epidemic, you can access off of this page. You can get to this from our homepage, which is www.oasas.ny.gov. I would encourage you to access this page and look at the information. We believe it's helpful and focused. We certainly hope you believe the same. Last thing that I want to talk about is in February of this year, we posted on our webpage, and I think we might be the first state to do it in a way that makes it available to everybody. It's publicly accessible. We created a bed availability dashboard. So now you can go to this tool, you can link it, it's right at the top of our homepage, and you can go in and do a search for available treatment beds across the state of New York. There's descriptions on the different levels of care, the different types of beds, which you can click on. And this is updated at a minimum every morning. Our providers are obligated to report to it every morning. They can report more often than that. But you go there, you can do searches by county, by zip code. You'll pull up the available beds. and you can scroll over with your mouse the information about the treatment program. It will provide maps on how to get to the program. It will provide you access to the phone number to the program, to that site, and to the people who you would talk to about getting treatment in that program. And with regard to this tool, one point I want to make, there's treatment beds available every day in this state in our programs. They might not be down the street from you. They might be an hour away. They could be longer. I will tell you, many families come to me when they seek help and ask to get as far away from where they live as possible for their loved one who's now going to deal with their addiction issues. And so there are beds available every day. And I would encourage anybody to access this tool before they look to go outside the state to get treatment. You know, our programs are licensed by us. They're regularly visited by us. They're subject to rules and regulations that protect the safety of the people. We stand behind the programs that we license, so I would encourage you, as you're looking for help, to access these resources to help get your loved one into treatment. So at this point, I'm going to stop, and I'm going to turn it over to Dr. Charles Morgan. Charlie.
Thank you, Rob. I am Charlie Morgan. I'm the medical director of the New York State Office of Alcoholism and Substance Abuse Services, and I'm very glad to be here with you today. And as you can gather, I think, from Rob's presentation, I work with some amazing people. Our goal at OASAS is to really do whatever we can to help people with addiction to access treatment, to help families to work on preventing the disease, and it's an honor and a privilege to work with people like that, and to partner with you as well, who are out there in the field working on this disorder. I'm going to move on to some slides here. All right, so I wanted to show this because if you look at the orange section and the gray section on here, all the different colors, what you see is that the orange section of this pie chart represents the number of people who come in with a primary substance use of alcohol. The gray section represents the number of people who come in with a primary diagnosis of opioid use disorder, and then the other sections represent other substances that you can look at on the slide as well. And while opioids have been increasing in frequency for primary substance use diagnoses, alcohol is still the #1 problem. And many times when we go into communities and when we talk to young people, we hear that alcohol is the problem that people want help with. So while we talk a lot about opioids, and I'm not minimizing the crisis in any way that we've been facing in New York State and that our people have been facing and our providers have been facing and our insurance companies have been facing, I don't want us to forget that there are other substances as well that we see. And the other thing to remember when we look at a pie chart like this is that many people who come into treatment have used more than one substance. So while our people may have a primary disorder of one thing, we're treating people who have disorders that include many different substances. And one of the things I like to think about, and that I think if you looked at the American Society of Addiction website, for instance, you would see that we don't use the words different substance use disorders. The word that we use is addiction, and I think that's one of the things that this pie chart could drive home for us. But we haven't gotten out of the woods with any particular substance these days. If we move on to the next slide, what we can see is that the opioid crisis has been going on for some time. If you can look at the bottom of this slide, you can see on that axis that there is a point where the thing starts to take off. Heroin is represented by the green line, and prescription opioids are represented by the blue or the purple line there. And what the green line represents is when heroin started to take off as a prominent substance. And that happened in 2010. Now, if we continued this chart out, and this chart only goes up to 2013, you would see that the green line has become steeper vertically than it is now, and that heroin use has really taken off. But the thing started at about 2010. And if we could come back to me for a minute on the camera, I want to show you something. I didn't include a graph of this, but the previous, we all remember the previous, well, some of us do, I do, I'm old enough to remember this, the previous heroin epidemic in the 60s, the 70s, and then the cocaine epidemic in the 90s, and now we're talking about the heroin epidemic that we have now. And I want to show you something with my hands. If you looked at the previous heroin epidemic, it would be about this big, if you can look between the space of my hands. If you look at the previous cocaine epidemic, which we were very alarmed about, it was about this big. And if you look at this, the size of this heroin epidemic that we have now, it's this big. It's much bigger than the previous epidemics were. And one of the things that has happened too is that the death rates from this heroin epidemic have exceeded the death rates from previous epidemics, so that now we have deaths from drug overdoses from heroin that exceed or at least equal the death rates that occurred at the peak of the HIV epidemic. And so our death rates are huge from this particular thing, and this particular crisis here. And so the pain that people are feeling, the pain that families are feeling, the pain that addicts are feeling is enormous in our state and in our country. We can go to the next slide now, and here is something that can drive the magnitude of this epidemic home even further. The top line, the blue line, represents deaths from motor vehicle accidents. And these are national data. These are from the CDC, from the Center for Disease Control. The red line that's solid represents deaths from drug poisonings, and from poisonings, excuse me. And the dotted red line represents the numbers of deaths from drug poisonings, which includes overdoses. That's what drug poisonings means. It means overdoses. And for the very first time in our nation's history, the numbers of deaths from drug poisonings exceeds the number of deaths from motor vehicle accidents. Now, you can look at the blue line, and you can see that one of the things we should be proud of from our people in enforcement, from automobile manufacturers, from people using their seat belts and car seats in appropriate ways, is that the deaths from motor vehicle accidents have decreased. And so we should be proud of all the agencies and all the entities that have been involved in that. But the other thing that's alarming, though, when you put it in this context and you realize that more people are dying from drug overdoses than from traffic accidents, it's an amazingly powerful way to think about the problem that we're dealing with and the impact that it has not only on society but on individuals. I want to present you with some information about New York State specific data, and these data were collected and aren't. Data lag behind. You collect them and then you can analyze them and publish them. These data, though, are from earlier in the current decade, and there's no reason to believe that these trends are different right now. But what you can see on this particular slide, if you look at the middle of the middle statement, is that between 2005 and 2011, New York State high school students who reported using heroin doubled, okay? And so there's been a huge increase between 2005 and 2011 in the numbers of people who have, high school students who have used heroin. It's not an uncommon thing anymore, and it's not uncommon in any county. It is not just an urban thing. It is also a rural thing as well. In counties, communities are being hit with this that never, ever expected to have their children using heroin. We also know, and this goes back to something that, that Rob was talking about early, nearly half of the kids who or young people who tell us, who have injected heroin, tell us that they started with opioid pills. Some of them started because they got a prescription from an athletic injury, like Rob was telling you about before. And some of them tell us, when we ask them where they got their opioids, some of them tell us that they got it out of medicine cabinets, and from their parents, from their parents' friends, but from medicine cabinets. And so we don't believe for a minute that people who leave those medications in their medicine cabinets are trying to hurt young people in any way. But we believe that that those medicines that are no longer of use to people, that are in medicine cabinets, can be dangerous things. And so one of the things that we've had is drug disposal sites in the state of New York. You probably know about these sites already, but places where people can take them back. And we've tried to educate people about the hazards of keeping medicines like that around. So that's what we found out. People don't start injecting heroin. They start with something else. And one of the reasons that young people have told us that they start with those other medications is because, in the past at least, they have believed that if they were prescribed by a doctor, they couldn't be hazardous. They believed they would be safer if they were prescribed by a doctor. And so we have had to educate the public about that. We've had to educate physicians, and as Rob says, we plan to do more of that as time goes on. The other thing that's remarkable about the slide that is on currently, that slide with the, that one right there, it just came back, is that 9 out of 10 people with addiction tell us that they started using drugs before they were 18 years old. So our educational things that I think Peggy will be talking more about are really not targeted just to adults. They're targeted to young people as well. And Rob had talked about that as well, that we, in one of the videos that he showed, that we want to help people as they're growing up to make choices as well. So I could talk for an hour about that, but we need to move on. So let's take a look at what these opioids really are. Well, they are many of them are naturally occurring substances. They're derived from the poppy plant, but since the first opioids that were discovered were derived from, we've learned how to synthesize them as well. Some of the man-made ones include drugs like fentanyl, which you've heard about now, and some of that's pharmaceutical fentanyl, which is about 100 times as potent as morphine. Some of the fentanyl that others have manufactured out on the streets is 80 times as potent as morphine. That's still very, very, very potent. And the naturally occurring ones include opium, tincture of opioid, those kinds of things. You saw in The Wizard of Oz, the reason that bullet is up there with Wizard of Oz, you saw the Wicked Witch of the West use the opioids, the side effects of the opioids, when she put the people, she said, oh, poppies, I'll sedate them. And so what she did was she put the lion, the Tin Man, and Dorothy to sleep in the field of poppies. That's one of the things that these can do. But really the only medical use for opioids is to relieve pain. That is the only thing that they do. Our patients may have taken them to relieve their pain, but eventually what happens is that a person becomes physically dependent on them. And if that person has an underlying disease of addiction as well, then that person is at particular risk for developing addiction to opioids and for having a devastating, can have devastation in their lives, in the lives of their loved ones as a result of that. So let's look at some of the other things that they do on that slide again that's up there. And The other things that happen besides pain relief is that they cause euphoria, and what that means is it's what people would commonly call the feeling of being high. Now, I can tell you that by the time our patients get to treatment, they're no longer feeling high. What our patients are doing is taking the opioids just to feel normal, just to stay out of withdrawal. So while they may call it getting high, most of them will tell you, if you ask them, that they haven't gotten high in a long, long time. They're only using them to be able to function. And that's what happens. Some of the other side effects that happen are particularly, some can be particularly disturbing. I mean, the fact that they cause constipation is a disturbing thing. They can cause itching. They can cause, commonly we look for decrease in pupil size. The dark part of your eye gets much, much smaller. But the other things that happen, nodding is one that I should tell you. Most of you will probably know what that is. But nodding is when somebody looks like this. And if Peggy would say, or Rob would say to me, Charlie, you're asleep. Could you say that to me?
Charlie, are you asleep?
No, I'm not. I'm awake. That's what a nod looks like. It looks like this, and then people come back to. That's disturbing. And when somebody's nodding, it's a sign that an overdose could be occurring at that particular time. But they depress the vital signs. They can cause respiratory failure, respiratory arrest, and death. Overdoses don't occur suddenly. They occur over a period of hours. And when those signs start to happen, it's time to start thinking about overdose and thinking about reversal, thinking about calling 911. So these are very serious things. So I talked a little bit about the underlying disease of addiction. And addiction is a primary disease. And if you talked to people who have addiction, many people would say, I never felt normal. I always felt like there was something wrong with me. And then I took my first drink and everything seemed fine. Or then I smoked my first joint and everything seemed fine. Or then I took my first X, Y, or Z. And everything seemed fine. As I was able to talk to people, I wasn't shy anymore, and I could go about my business. And then the drug wore off, and then I needed some more. So what we hear from people is that very, very thing. And I think it's important for us to remember that there are signs and symptoms of addiction that can pre-exist the use of the drug. And that those people, whether they have a genetic predisposition or whether they've had trauma or for whatever reason those signs and symptoms exist, those people may be vulnerable. But one of the most important things to talk about when we're talking about prevention is whether there is a family history of problems with drugs or alcohol. So we're going to look at some more video content right now. And this is a real New Yorker. And we have several of these videos with real New Yorkers. And I want to really, really thank the people who made these videos because they came forward and they told us some of their very, very personal stories. And I believe, probably to a person, the reason that they did that was because they wanted to carry the message. They wanted to carry the message not only that they're of the devastation that addiction can cause, but they wanted to show that recovery is possible. So we're going to see a New Yorker right now, Tatiana, who's going to tell us a little bit about her story about what addiction did to her. And we'll take a listen to that.
Withdrawal is one of the most excruciating things, actually, that I've ever experienced in my life. It feels like there's a million pins and needles going through your body. You feel like you want to die, and all you're thinking about is getting high. My addiction brought me to very dark places. The craziest part about all of it was that I thought that it was normal.
Opioid and heroin addiction happens fast. Don't ever start. To learn more, visit combatheroin.ny.gov.
Okay, so there you go. It's hard to watch that and not be moved. But I want to talk a little bit about recovery now as well. I'll be turning it over to Peggy in just a couple of minutes. But I do want to talk about recovery. So on the slide, what I want you to know, and what all of these New Yorkers, what Rob, what Peggy, what we all want you to know, is that recovery is possible. The disease is worth treating. That people get sober, they stay sober, they do remarkable things. I want to also let you know that that recovery is not a state of misery. I happen to be in long-term recovery myself. For me, that means I haven't used drugs or alcohol for over 35 years. That makes it possible for me to be here with you today, to be part of my family, to be involved in my community, to do all these things. And so I am not a miserable. Well, I don't know, you could ask my colleagues if I'm miserable, but I don't think I'm a miserable person. So I think many of you who know me would know that that's not true. So recovery does not have to be a state of misery. However, as Rob stated before, this is a chronic disease. And by that, we mean that it is a lifelong disease. Just because we happen to be in recovery like this doesn't mean that our brain doesn't still have that disease and that we're not vulnerable to relapse. If relapse does occur, and I want to go back to the slide for a few minutes so we can look at the bullets there, but if relapses do occur, they are part of the disease process. And one of the things that we are firmly committed to in OASAS is that when those relapses do occur, people who relapse should be able to access treatment. There is no maximum number of relapses that a person could have, which would mean that they didn't deserve treatment anymore. There is no maximum number of heart attacks that people can have where they would not deserve to be treated for their heart attack again. So relapses can occur. But even when relapses aren't occurring, it's important to remember that people who are in recovery do have a chronic illness. I think the best results for recovery occur when the family is involved and when the family is supportive of the recovery. And so we want to reach out to families to provide them support as well. Schools, jobs, all those kinds of things can be supportive. And when those other entities come into play with support, recovery is enhanced. Sometimes people who are in recovery, particularly people with opioid use disorder, need to take medications. Those medications that those people take, whether it's buprenorphine, Vivitrol, methadone, do not interfere with function in any way. People who take those for the long term, who are in recovery, can run businesses, they can take care of their families, they can do any number of things that any of us could do. We can't tell the difference between those people and people who are not taking the medications. Not everybody needs medications. Not everybody who's on medications for a while needs medications forever. Some people, for instance, an alcoholic who's going into a risky situation on a plane or something, might want to take antabuse for a while, just for safety reasons, even if they've been sober for a year or two. So I think the medications are a very, very important thing, but they don't affect the way that a person appears to be, or the level of function that a person can have. I think the other thing that's misunderstood about recovery when we talk about this being a disease is that some people think that takes responsibility. We're trying to take responsibility away from the person with the disease for their well-being. And that is exactly the opposite of what we're trying to do. When we talk about this thing being a disease, what we're trying to do is empower people to understand what the treatment for their illness is and to be able to utilize those tools that we give them so that they can get their lives back and so that they can have so that they can know. I have a friend who says in her talk about her own recovery, she says she hears a lot of people say they don't know why they're sober today. And she says, in her talk, she says, if you don't know why you're sober today, you better take a look at what it is, because if you don't know what you're doing to stay sober, you might stop doing it. And it's a great point right there. So when we talk about the fact that it's an illness, and we know in the brain what's happening with that illness, we're actually trying to be able to give people tools. So I want to look at another video right now that is a video that shows us some of the stuff that happens before. You're going to see pictures of people in this video, again, real New Yorkers who are in recovery, and you're going to be able to tell the difference. And again, I applaud the people. After that, I'm going to turn this over to Peggy Minot, who is our Director of Health Initiatives. So we can roll the video.
This is the face of addiction. Addiction doesn't discriminate.
Alcohol,
smoking weed, pills,
crack,
K2, spice, acid,
cocaine,
crystal meth,
heroin.
This is also the face of hope. Addiction is a disease. Help is available. Visit the New York State Office of Alcoholism and Substance Abuse Services website today.
Thanks, Charlie. Thanks, Rob. Yeah, that was a video that we put together, and it aired in February. And we tried to demonstrate that addiction doesn't discriminate, people do recover. And I think what you're going to see in our coming new launch of public service announcements are that addiction, once again, addiction doesn't discriminate, that alcohol is a gateway substance. We don't want to focus on any one substance, but I'm going to show you in my part of this presentation some of the materials, some of additional materials that we may not have touched on, and how you can find them. All of the materials that we've developed are free, and you can access them either through the OASAS main page, which is oasas.ny.gov, or at combatheroin.gov. So if we go to this slide that hopefully you'll see, this is really where we started to focus 2 years ago when we focused on heroin, and we progressed and evolved to that it doesn't start with heroin. No one wakes up one morning and says, I think I will start as my first substance with heroin. We've since developed several tools and resources that are available for the community, and one in particular that I want to talk about is the Talk to Prevent campaign. And you'll see in the next slide, you'll see that 49% of high school students are reporting that they have consumed alcohol in the last 30 days. And that's something that we are going to be driving home in the next set of materials that come out from OASAS, in that oftentimes families and adults look the other way when it comes to alcohol or even marijuana. So we want to make sure that people understand that alcohol is illegal. Underage drinking is illegal. It's not only not a good thing because it can lead to other substances, but it is illegal. And the Talk to Prevent campaign has a lot of information that really focuses on alcohol and how you can have that conversation with a young person in your life. Something that's going to launch in the coming weeks is information on college students and how to have conversations with college students. So be on the lookout for that information. The next slide demonstrates a real focus on prescription pills. And you've heard Rob and Dr. Morgan speak about medications and being in a medicine cabinet, and that's really where people start with this path towards addiction. Oftentimes it's right in our own homes, and it may not be in the family's home, it may be in a friend's home. So we have developed some tools and resources that are available where you can track your medications. It's called the Medicine Cabinet Inventory Card, and you can go in and look at all of your medications and track them and monitor them. Certainly medications are valuable and they help people. However, when a medication is finished and you have extra pills available, that is a time to really assess whether or not you need them in your home. If you don't need them in your home, you can take them to a safe disposal site, and those listings are on our website, or you can dispose of them yourself. We ask that you not flush them down the toilet, but you dispose of those, whether it be in coffee grounds or cat litter, and get them out of your home, because they're of no use and they can only cause danger to you or family members or their friends that come into the home. So the next slide that I want to show is really a highlight of what's on our website. And we developed this website 2 years ago. We're building on it on a regular basis, but this is the combatheroin.ny.gov website. And this has received unprecedented response from the community. Since we launched this on September 22nd, 2014, it's received over 800,000 page views. So the community is telling us that they're desperate for information. There's information on prevention, as you see here, warning signs, getting help, real stories. As you saw, some of our videos were real New Yorkers sharing stories, and we turn those into public service announcements, and then free resources. Once again, I can't stress enough, all of our materials are free of charge and available to you. We have an order form that's available under the free resources section, and you can order materials. They can be delivered directly to you, directly to a provider, or to a location where you're going. Certainly, one trend leads to another, and synthetic marijuana, or also synthetic cannabinoids, also known as K2, spice, rocks, candy, and other names. These are man-made chemicals, and Dr. Morgan has done presentations on synthetic cannabinoids, and we'll be doing those again. It's been heightened recently, and it seems to be in areas that it shouldn't be. It's targeting the vulnerable population, and it's targeting, I'll let you guess, when it's in mint flavored or strawberry flavored and in packaging that is shiny and attractive. It's targeting teens. So we ask you to be aware of that. This information draws your attention to where people can be getting help, but we're going to be developing some new materials that focus on what you can do if you see a store selling this. We ask that you call. There's an 800 number. It's 1-888-99-SALTS. So 1-888-99-SALTS. We ask that you report it. It's anonymous, and we'll be doing some promotion on that. But the next video that we're going to be showing you is a video that launched last fall, and it focuses on synthetics. So here you go.
Listen up, New York.
There's a new drug out there.
It's trying to destroy our generation.
It's called synthetics.
So some guy thought it might be a good idea to spray poison on some herbs and then sell it to you.
No, it's not marijuana.
It goes by names like K2, spice, rocks.
Causes hallucinations, rapid heartbeat,
vomiting, seizures.
And it can kill you the first time you smoke it. We gotta have each other's backs.
This is our future.
and the future of New York.
It's saying no to synthetics. Go to oasis.ny.gov or call or text the Hope Line.
And the next slide, you'll see a poster which we've been distributing all over the state of New York. We've been sharing this. We've been putting it in subways. We've been doing a campaign to really get this message out. We have posters, as you see here, the number that you can call to report it if you do see this being sold in a corner store, because it is illegal, and they're doing, a major crackdown to try to catch and identify stores that are selling this. It is illegal. So please help us, help the community, and report it if you see it being sold. The next slide is information that is in the form of a business card size. We call it a palm card, and we've been told by different people that are responsible in shelters that this type of information is really helpful to the community, where it's very simple. It reminds people that this is not a joke, that it's poison, it can make you sick, and where they can call, who they can call if they are at that point in time, they are ready to change their life and get some help. So as you heard from Rob talking about new legislation, that if someone was ready at that point in time, they wouldn't be turned away. So never have we been more excited in the field with the new updates that Rob and Dr. Morgan were talking about. But this information is so serious, so if someone is ready to get the help, they can get it immediately. So here's an example of a billboard that ran in a city in New York, in the Bronx, as you see here. And several of our community members, coalitions, have asked us if they can repost this information. Can they put their logo on it? And the answer is absolutely they can. So all they need to do is contact us. We'll assist them with how they would be able to put their information on there. But we have a lot of materials that are free of charge, and if you have the means to get it out there in the community, let us know and we'd be more than happy to help you. The next tool that I am very proud of and I'd like to make sure that you're aware of, it's called the Kitchen Table Toolkit. And this is a new tool that we have made available to on our website, but to schools, to counselors, to coaches, to administrators, to teachers, to make individuals aware that there's a resource that they don't have to reinvent the wheel. There's a resource with talking points, with how to conduct a presentation if you're talking about opioids and heroin, and it includes 2 guidance documents, one talking to the community, one talking to an individual, whether it be a group setting, whether it be in a classroom, whether it be right at your kitchen table having a conversation with one person. We have 2 videos that are targeted, one again for the community, one for young people, and we're going to show you a couple of those videos, but you'll see here all of this information is available, once again, free of charge. It is available. These videos are available via YouTube, so you can download them from the OASAS site. So I'm going to show you a sample of the first video, which talks to the community. This is an excerpt of the video, and the video is actually 17 minutes long, so you're going to see about a minute of it.
The denial was there huge. You know, not my child, this can't happen to him. And I would say that any parent that's dealing with a child that has a substance abuse problem probably has some level of denial present because it's terrifying.
If a parent is sitting there saying, not my child, I would ask you to think, why not my child? You all have risk factors, they're in school. The face of addiction is not what it was in the 1970s. It is the high school cheerleader, it is the captain of the football team, it is anyone who you can think of could be that addict.
You know, at one point I was an honors student, varsity athlete, and imagining myself, you know, away at college and living a beautiful life, and within just a couple years I was stealing and committing criminal acts just to support my habit. What parents can do is start asking more questions. You know, I saw a really awesome statistic released recently that children whose parents talk to them regularly about the risks of addiction and alcoholism are 50% less likely to become addicted to alcohol or other substances.
So the action is having the conversation with the young person. And the next video that I'll show you is, again, an excerpt of that video that focuses on the conversation with the young person.
At the end of October, he OD'd. My son found him, my 23-year-old son. He found him in the bathroom. He was blue. He woke us up. We came down. We called 911. They came to the house. They administered Narcan. It didn't work. They rushed him to the hospital, had him in the ER. And he was in ICU for about 3 days. He did wake up. And when he got out of the hospital about a week later, he had a severe brain injury.
And then after that, I started to do the opiates. I started doing Roxy's, Oxy, and then the next thing was heroin. And then that was kind of the beginning of the end for me at that point.
I just thought, you know, an opiate is an opiate. And if I can't get the type that I want, then I'll get this other type instead.
And by the time that I was 17, I had tried heroin for the first time. Not because I ever wanted to try heroin.
But like the thing about heroin is that like you're emotionless. Like after doing it for a certain period of time, like you have no emotion. Like you're not sad, you're not happy, you're just like numb, you know what I mean? Like no emotion at all. So like I just didn't care.
Everything just fell apart in my life. I lost jobs. I lost like trust and faith. The people that knew me since I was a baby, people didn't even want to look at me. People wouldn't answer my phone calls.
When I stole my mom's work laptop computer and got her fired from her job, that's when I really knew it was a problem. And when I couldn't pass a drug test to save my life.
So as you could see, there's two different videos that are available. They're available on the OASAS website, on the Combat Heroin website as well. And it's a section called the Kitchen Table Toolkit. We encourage you to make yourself available and make your audiences, your networks available to this information, because it's helpful to have it in a consistent package, and it delivers a really good message with real New Yorkers. We've traveled the state of New York. We'll continue to travel the state of New York, hearing stories, videotaping stories, and putting those on our website. If you have a message or if you have a story that you think would be important for me to hear, I work on all of our campaigns. I would love to talk to you and get that information out so that everybody can be aware of it. The resources, the information that you see on our website, there's a link to the main OASAS page, the Talk to Prevent materials, the Combat Heroin website, the Kitchen Table Toolkit, the Good Samaritan Law. We want to make sure that individuals understand the facts about the Good Samaritan Law and that they can save a life by calling 911. The Spotlight on Synthetics. We have a lot of information about synthetics. We ask that you make yourself familiar with where that is. And download the materials from the website. Certainly, we wish that we could send you in bulk all of these materials, but a lot of this information is available free of charge for you to download, and we can assist you if you want to put your information on there. Certainly, you can order any of our materials. Some of our materials are available to be delivered, not all of them are, so look on the website and you'll get more information about that. So identify who your stakeholders are and connect with them, because we have power when we work together. Identify your local prevention provider, your treatment providers, your recovery centers in your area, and we hope that you access the materials and tell us what you think of them. And I'm going to turn it back over to Rob and give you all of our contact information as well.
So thank you all. I want to close by saying the following. So I hope what you saw in this presentation, we're actively engaged, working on addressing this epidemic, and it starts at the top, from our leader, Governor Andrew Cuomo, our Commissioner, Arlene Gonzalez-Sanchez, all of us, our field. We're all in this together. I think that's one of the comments the governor made when he signed the bills. So if I can leave you with anything, I hope you feel, A, that we're going at this full bore, 150%. And the reason we are, and Dr. Morgan talked a lot about it, that people do amazing things. Recovery's possible. There is hope too. I mean, that's one of the other things that we've really tried to focus in on. It's tragic, some of the things that have happened, and the number of people who've died from heroin opioid overdoses is staggering, and it's just tragic what it is. But there are a lot of people who now, and even hopefully more so because of all the actions we're taking, can reach that point where they get treatment, they get the help they need, they enter a life in recovery and do the amazing things that we see people who are in recovery do every single day. So with that, we'll conclude, and we thank you for watching this video.
I'd like to thank Rob, Dr. Morgan, and Peggy for your time today. Your feedback is appreciated. If you could take a moment to fill out our survey, that would be wonderful. Thank you for joining us.